just a few more minutes. I'm going to give us 2 more minutes to people log on. We have some now, but I'll get started at 10:02.
10:02. Okay, yeah, it's 9:59 now. I have 1 hour, right? Or 45 minutes, I forget.
You have 45 minutes. That'll give us 15 minutes for questions.
All right. All right. I'm going to leave my clock on here so I can have a close eye on it. Okay. So this is for Rutgers alumni.
Yes. We often get other people who register as well. We didn't close it to only Rutgers alumni.
Yeah.
That's who it was marketed to.
And I'm used to talking to medical people, you know, so I have to keep that in mind, that I'm not just talking to medical people here at all.
Right.
That's very important. I have to remember that. Yeah. I almost never lecture without my white coat, you know.
Well, you can do whatever you want. Pull Mr. Rogers, wear that half the time, put on your white coat.
No, that's okay. That's okay.
All right. I think we'll officially get started. We have some people on now, and so I'll just do the intro here. So good morning, and my name is Karen Green, and I'm the Director of Alumni Engagement for Rutgers Biomedical and Health Sciences at the Rutgers University Foundation. Thank you all for being with us this morning. I hope that you're all healthy and safe at home. During this time of social distancing, the Rutgers University Alumni Association is offering a variety of programs to highlight the important work being done at the university to help keep alumni connected. Today, we are honored to have with us Dr. John Bach. As a proud alumnus of the Rutgers University New Jersey Medical School, Dr. Bach serves on the faculty as a professor of physical medicine and rehabilitation, professor of neurology in the Department of Neurology, and medical director of the Center for Ventilator Management Alternatives at University Hospital in Newark, New Jersey. He has over 400 peer-reviewed scientific articles and book chapters and 10 medical textbooks on neuromuscular and pulmonary medicine, on which he has lectured in over 70 countries. He has received many awards for excellence in research writing, and others include the UMDNJ University Excellence Award for Patient Care and the Newark Beth Israel Health Foundation Humanism in Medicine Award. Before I turn it over to Dr. Bach, please note that all attendees have been placed on mute for the duration of the discussion. If you have questions, please send them via the Q&A option at the bottom of your screen throughout the presentation. Them directly to all panelists. Following the discussion, I will read your questions aloud to Dr. Bach, and we will get to as many questions as possible. It is now my privilege to turn it over to Dr. John Bach.
Yes, thank you very much. Thank you very much, Karen. And, you know, as an undergraduate, I didn't go to Rutgers. I went to Stevens Tech in Hoboken, but I know that Rutgers is already famous for a number of things. And one of them, of course, is inventing AstroTurf. But another is inventing streptomycin, which cured tuberculosis back in 1947. Probably the third thing, ever since this third thing happened, I haven't had to explain how to spell Rutgers to anybody. A few years ago, our football team lost 76-0 to Michigan State. And so Rutgers has become famous on many, many areas. So now I want to introduce another area, and that's the consequences of our current medical system and fee-for-service nature. And let me talk about how we spend money for healthcare. In 2018, we spent $3.6 trillion for healthcare, including more than $500 billion just for administrative costs. And it's been going up by almost $500 billion per year. In fact, I'm not even going to talk about this year. This year is going to be probably much worse. And This has resulted in insurance premiums increasing by 16 to 22% per year. Now, to put this in perspective, our entire federal budget is $4 trillion a year. This is 5 times more than we pay for our military. And we pay more for our military than about the next 24 countries combined. Yet we pay 5 times more for healthcare. By comparison, we pay $160 billion for higher education. Medicaid and Medicare now are costing us over $1.3 trillion a year. Now, what are we getting for this $4 trillion a year? Well, we die 4 years younger than in countries that pay 1% of their GDP. We pay 23% of our gross domestic product for healthcare. And we're rated 37th, as I mentioned, and we die 4 years younger than countries that pay 1%, where the government pays 1% of its GDP for healthcare and guarantees it for everybody. The number 1 rated country is France, but they pay 14% of their GDP. But they live 3 years longer than we do. And Italy is number 2, and they spend 9% of their GDP. Singapore is rated 6th. The government spends 1% of its GDP for healthcare. And again, they live 4 years longer than we do. If we had the same healthcare system as Singapore, we would be in the black by $1.8 trillion per year. This is money that we could spend on anything, exploration of space, development of medications, healthcare, anything for the poverty programs and so on. I published this paper in 2014, and I don't think it's changed very much since then. The Singapore healthcare system is fundamentally different than ours, and I'll explain a little bit about it. But $1.8 trillion saved instead of being $1.5 trillion in the red every year. Okay, so how does Singapore do it? Well, there are no benefits when you get a salary from your employer. However, you have to, by law, put 20% of what you earn into 2 accounts that can only be used for healthcare, accommodations, and education. You cannot buy cars with it. You can't go for vacations. You can't buy television sets or anything like that. But your employer also must put 18% of what he pays you into these 2 accounts. So if you start working at age 18, 38% of the money you earn will be in these 2 accounts. They are pre-tax, they're invested for you. The average return has been about 6%. And by 50 years of age, most people in the 1 medical account have $500,000 already that they spend for their health care. Now, those accounts can be combined with 9 other accounts in your to pay for medical expenses for a chronically ill person or a disabled child. So accounts can be combined to do this. And the government has a sort of a Medicare plan, which is that when you die, those accounts are your estate. It's your money. However, the government takes about 2% of it for their central catastrophic care fund for people who don't have enough money in their accounts. Also in Singapore, they have a couple of very barbaric laws. So for example, they passed a law saying that parents must take care of their children. And they passed another, even more barbaric law that children must take care of their parents. These parents do not go to nursing homes unless you pay for insurance to cover that. On the other hand, when Singapore split from Malaysia in 1971, they were equally poor. Singapore has no natural resources. They were equally poor to the Malays. Today, however, the average family in Singapore can afford to have multiple Malay servants. So if you have a parent who is severely disabled, typically they go to the homes of the children, and the children hire servants to take care of them. As far as parents taking care of their children are concerned, sometimes this can be a little carried away in the United States. I have 3 patients with a muscular dystrophy who are in motorized wheelchairs and who have nursing care 16 to 24 hours a day, and they're on ventilators. Now, these 3 children are brothers. They have 4 other brothers with muscular dystrophy. They have the same last names. And these 7 children with muscular dystrophy have 9 brothers and sisters who do not have muscular dystrophy. Now, they've never met each other because each one was taken at birth and put into foster care at taxpayer expense. This could not happen in Singapore. If you're going to have the child, you are going to raise that child. By the way, these costs, including medications and nursing care, can amount to $1 million a year per child for 7 children. So you can add that up as to what it's costing taxpayers, because parents don't necessarily have to raise their children in the United States. The Institute of Medicine estimates that unnecessary and inefficient healthcare medical services cost $1 trillion per year. By other estimates, it's $2.8 trillion per year. By my estimate, it's certainly $2.8 trillion per year. And this is the only country where the most common cause of personal bankruptcy is being unable to pay medical bills. If you get cancer and need chemotherapy and you're not 65 years old with Medicare and you don't have insurance to cover this, you will go bankrupt. Nobody has ever declared personal bankruptcy in Singapore, Canada, or anywhere in Europe. Even though the medical systems are really very different in Canada, Europe, and in other countries like Southeast Asia and China. 25% of Medicare spending occurs for the last year of life, and a lot of that is for invasive procedures that are very debatably necessary. Now, this is just a brief list of books about overtreatment in the United States and what it costs in terms of quality of life and in money. In cardiology, in oncology, in surgery, many procedures are done. You know, when I was 4 years old, I had a tonsillectomy. They don't do tonsillectomies routinely on everybody anymore. That's just one example. I can give you many, many other examples of treatments that have been done and have been proven and retrospectively to have not been helpful. Physicians have been using bleeding for over 4,000 years. Even in the 1920s, physicians would bleed patients who were hemorrhaging to death. So if a patient is hemorrhaging, the treatment was to bleed them further, because that's what physicians were expecting to get paid for. In fact, The Lancet is one of the most famous medical journals in Britain and in the world, and it's named after the lancet that physicians use to bleed patients. Well, on this list, there is no book on respiratory management, and I'm working on that. And I hope to have it finished after I finish the current book I'm working on. But the point is that I'm going to give you an example of enormous waste and damage caused by when medical innovations that save lives and money are ignored. And when does this happen? When your medical system is overly influenced by the profit motive and special interests. And when learning to more humanely treat people is stifled by the profit motive and special interests. In the last 6 months of life, many patients get tracheostomy tubes. In fact, tracheotomies like this are the most common procedure in all trauma hospitals and in many hospitals in the country. If they were not done, it would cost the hospitals $40 to $50 million per year, many of these hospitals, all of the trauma hospitals essentially. Tens of millions of dollars per year. And of course, many surgeons' entire salaries, or the large part of it, is based on doing tracheotomies, even though much, if not most of the time, it's completely unnecessary. This is a man who is strong enough to work as an accountant and walk around, but not strong enough to breathe. He almost got a trach, but in our hospital at University Hospital, we saved him from getting one by not exactly rocket science. We simply deliver the air to him through a mouthpiece. So the ventilator, instead of delivering the air through his neck and into an invasive airway tube that goes into his windpipe, actually delivers the air to his lips, and he grabs the mouthpiece and ventilates his lungs. He did this for 15 years after he would have otherwise gotten a trach tube and went back to work full-time as an accountant. Now, this is a woman who had a tracheostomy tube for 3 years. She was on chronic intravenous antibiotic therapy for 3 years because of the chronic bronchitis caused by the pathogenic bacteria that colonized her tracheostomy tube. Again, the tracheostomy tube goes through the neck and into the windpipe. Now, the antibiotics cannot attack bacteria on that tube because the tube has no blood supply. So the antibiotics cannot get to the tube. So this chronic bacterial colonization of her lungs and airways, which everybody with a tracheostomy tube has, cannot be rid by giving antibiotics. You can only affect the bacteria when they get into the blood and into the tissues that have a blood supply. Well, she came to our hospital, University Hospital, and we removed her tracheostomy tube. She also then learned how to frog breathe. Now, for those of you who did high school biology, when you picked a frog and studied the frog, you may have noticed that frogs do not have diaphragms. They don't breathe the way we do. They actually breathe with their tongues. And I'll show you, if you can see me, they go, they use their tongue to piston boluses of air into their lungs, and they could literally breathe all day that way. After we took this woman's tracheostomy tube out, even though she had no ability to breathe at all, she could not survive without a ventilator for more than 2 or 3 minutes until ultimate brain death. She had no ability to breathe at all. However, with frog breathing, she could breathe all day without the ventilator. Now, when someone is ventilated through a tracheostomy tube into their necks, they're always frightened of accidental disconnection. In fact, in every hospital I've ever worked in, at least one patient has died because the tube got accidentally disconnected. And even though there's a low pressure alarm that would normally signal for help, when the tip of the tube is against the skin or against the dressing, the low pressure alarm may not sound and the patients die. And the patients know that this is a thing to be afraid of. Well, not my patients who can get their tracheostomy tubes out and learn how to frog breathe. What is continuous non-invasive ventilatory support? Well, as I mentioned, this is not rocket science. You can simply deliver the air through a 15-millimeter mouthpiece or a nose piece that my patients use for sleep. Or you can use an abdominal belt, something called an intermittent abdominal pressure ventilator. Now, believe it or not, this was devised in 1937. It's been used since 1948. And what it is a girdle with an air sac in it that goes under the clothing. And the air sac is against the belly. And the air comes from the ventilator, not to the nose, the mouth, or the throat, the neck, but to the bag in the belt on the stomach. And it pushes against the belly, moves the diaphragm, and ventilates the lungs. Again, this is not high technology. In fact, that's why it's not being used, because it's very difficult to make money by doing these simple, useful methods. You certainly can't make any money by frog breathing, and but you can make money by putting in invasive airway tubes. Now, this is a man who was in an explosion. The explosion basically destroyed his lungs. He was intubated 19 times. Now, for those of you who don't have a medical background, being intubated means that the physicians take a tube, put it through your nose or your mouth and into your throat and into your windpipe. And then they hook you up to a respirator or a ventilator. Same thing, it's a ventilator. The ventilator ventilates the lungs. Well, this man was intubated 19 times over about an 18-year period, and he couldn't stand it. He didn't want it anymore. He wrote an advance directive. He said, "Don't intubate me again. Let me die." Well, he went into respiratory failure again. His carbon dioxide went way, way, way up, over 80 millimeters of mercury, more than twice normal. And he was lying in a hospital bed with agonal breathing, like that, about to die. And I said to his attending doctor, I said, well, he doesn't want to be intubated, but what about non-invasive ventilation? He said, oh, sure, you could do that. So we put a mask over his nose and mouth and pushed the air into his lungs. His carbon dioxide came to normal, and he woke up. If you or I walk into a vat of fermenting grapes where the carbon dioxide level is 200 centimeters of water, we would stop breathing. It's millimeters of mercury. Oh, now I forget. But at any rate, we would stop breathing. We would stop breathing. When the carbon dioxide goes to 80 or more millimeters of mercury, the patient stops breathing. Well, when you lower that carbon dioxide, patients wake up. So he woke up, but he needed to use non-invasive ventilation continuously, day and night, for the next 11 months. And after 11 months, he died peacefully at home. So we gave him an extra 11 months of life without a tube through his neck. And again, here he is with a ventilator on a walker, with the mouthpiece in his mouth, walking around, and he went home and lived this way for the next 11 months. How long can you use 24-hour non-invasive ventilatory support? Well, I still have multiple patients who were taken out of iron lungs in the early 1950s. This woman has been using 24-hour non-invasive ventilatory support through a mouthpiece by her mouth for 66 years. And for the last 40 years, she's worked full-time as a rehabilitation counselor. She has earned her living, even though nothing works below the neck. Only from the neck up is she normal. She can speak on the phone, rotate her neck, but she has no use of her limbs. But she has been working for 40 years. I have to tell you, when I first started working as a rehab doctor, I had a 31-year-old woman who was a slalom ski racer. She was so flexible, she could put her hands flat on the ground, 1.5 feet in front of her, when I can barely get past my knees. She had a medical file this thick, and had never worked a day in her life because she had fibromyalgia. So if you touched her back anywhere, she would have pain everywhere, and she never worked because she said she had too much pain to work, but she was a slalom ski racer. But she was fully disabled for working, but not for personal care. This woman was fully disabled for personal care, but she could work a full 8-hour shift a day for 40 years. Another woman who's also well over 70, I think she's 77 now, 66 years, no, she's 75 now, 66 years of 24-hour non-invasive ventilatory support. She's got a sip and puff control motorized wheelchair, mouthpiece next to it. She lives with personal care assistants, not nursing care. These patients live with attendant care at the minimum wage in New York City. They don't have nursing care at $60 an hour. They have attendant care at $11 an hour, or 12 or 13, whatever the minimum wage is. In fact, the city of New York didn't pay the minimum wage, and I don't even know if they still are, because they said, well, if the attendant is living with you, we're not going to pay overnight. We're going to pay a $16 overnight differential and pay the minimum wage during the day. So you're talking about expenses infinitely less than patients with tracheostomy tubes who must have nursing care. Almost all law. Now, these two children have something called Wernicke-Hopkins disease. It's the most common cause of sudden infant death syndrome. These kids stop breathing during sleep around the age of 5 months. Nobody survives 18 months of age with this disease unless they are put on respiratory support. Now, I told the parents of multiple kids that they would be dead in 1 year if they did not get a tracheostomy tube, because they have no throat muscles at all. So I assumed, like every other doctor, that they would not be able to protect their airways from airway secretions dripping in and getting pneumonia. Well, the first boy, mom got pregnant for the second boy after I told her that the first boy would be dead within a year. But I was a little bit off. Now they're 25 and 23 years old. They have been 24-hour vent dependent, non-invasively on nasal ventilation, as you can see, since 4 and 8 months of age. And both have had to take all nutrition by stomach tube since 4 months of age. They've never been able to make a sound, not a vowel sound, not a consonant sound. They have never been able to speak. They operate their computers. They graduated high school and go to college. And now they're not the only kids whose parents I said would be dead within 1 year without a tracheostomy tube. But I have been wrong. I have 9 these patients now over 20 years of age. None of them have tracheostomy tubes. All of them are 24-hour non-invasive ventilator support users. Imagine parents refused tracheostomy tubes, and they were right. This is a woman who had cancer, was on chemotherapy, was very, very weak because of her medical treatments. And again, the doctors wanted a trach tube in her neck. But we managed her with non-invasive ventilation. She used nasal ventilation at night and mouthpiece during the day, and she ultimately died from her cancer. And people with morbid obesity who are too weak to breathe against all the extra weight, you can have a normal diaphragm, but if you cannot move all the weight on your belly, you cannot breathe, and you can become 24-hour ventilator supported. He had a tracheostomy tube. We, of course, removed it and managed him for 10 years on non-invasive ventilation. And with normal throat muscle strength and normal lip strength, it's easy for him to use mouthpiece ventilation all day long. And he used nasal ventilation at night. Now, this is a patient with Lou Gehrig's disease, amyotrophic lateral sclerosis. She was on trach ventilation 24 hours a day for 2 years. She didn't want the trach, so we took it out. We removed the trach. We test to see that the upper airway is open. Then we put a pressure dressing on it, because this air going through the mouth naturally wants to blow out through the trach tube. But that has to be prevented so that the skin will close. So we put a pressure dressing on it. And where do we get the dressing from? Well, we get a little old lady who has a cane. We take the cane tip and we cut down the walls, and we put the cane tip over the ostomy. It's great because they're designed to have good friction. And then we continue the pressure dressing with an ACE bandage that creates counter pressure. And so the patient then can use nasal ventilation at night and mouthpiece ventilation during the day, or a pneumo belt, like I mentioned before, on the belly, and use that instead of a tracheostomy tube. Now, patients with ALS, Lou Gehrig's disease, are the only patients with any neuro that eventually do need tracheostomy tubes. Nobody with any muscular dystrophy, spinal muscular atrophy, nobody with spinal cord injury, nobody with obesity hypoventilation ever really needs a tracheostomy tube. They can always be managed non-invasively, and they do far better managed non-invasively than with tracheostomy tubes. We've taken the tracheostomy tubes out of 24-hour vent-dependent spinal cord injured patients in the early 90s, and now for 25 years, they're still using non-invasive ventilation, and they avoid all the problems that would have otherwise killed them. 60 to 80%, in fact, for spinal cord injured patients, 60% die because of complications of the tracheostomy tubes, mainly because of the cuff that can destroy the trachea and the airway. When you take the tracheostomy tube out and teach them how to frog breathe, they have no more airway secretions, and they do infinitely better than if you leave the tracheostomy tubes in, which is conventionally what's done everywhere. Because there's no incentive for going through the work of taking the trach tube out, or for avoiding it in the first place by extubating patients without it. All the incentive is to put the tubes in, send them to LTACs that get paid $150,000 a year a patient to wean them. And I think I can still go into that. There's still a little bit of time to discuss the finances of this. But this patient, her skin closed within 3 days, as it usually does, and she was very happy for the next 13 months to go without a tube through her neck. But with Lou Gehrig's disease, there's spasticity in the upper airway that closes the throat and can make non-invasive ventilation impossible. This only happens in upper motor neuron disease, which is brain disease or ALS, Lou Gehrig's disease, and in no other conditions. So she had to get a trach tube again when her upper airway was closing, and she absolutely refused. She said, "I'd rather be dead than get another tracheostomy tube." So after 13 or 14 months of this, she died by choice. Now, this is a young lady from Santa Barbara, California. A year and a half ago, when Santa Barbara was burning because of all the fires in California, she had never used a ventilator, but she got a cold. And because her cough is very weak, and she had never been set up with anything to help her cough or breathe, she went into respiratory failure. And while she was unconscious and sedated and intubated with that tube through her mouth into her airway and on a respirator, she was medically sedated. And then the family was told she needed a tracheostomy tube because she was too weak to breathe. Well, she was too weak to breathe. She got the tracheostomy tube, woke up, and was horrified. So they put on for her benefits and raised $80,000 to find anybody who would remove the tube Well, I'm the only person that would remove the tube. So she spent $40,000 for an air ambulance to fly her to Newark, New Jersey, came into our hospital, and we took out her tracheostomy tube. She's a school teacher, and she works to this day. She has something called spinal muscular atrophy, same as those boys with spinal muscular atrophy, type 1 Wernicke-Hopkins disease. But she doesn't have type 1. She has type 2, which is much milder. And so she can speak clearly. She's able to swallow food, and she's able to work as a school teacher. So we took out her tracheostomy tube, and there she is, and very, very happy. In fact, about a year later, while I was lecturing in San Francisco, she drove up 8 or 9 hours, or she was driven up by her husband from Santa Barbara, just to tell all the people in the audience how wonderful it was not to have a tracheostomy tube, and how wonderful it was that we could remove her tube in New Jersey. So intubation is sticking a tube through the nose or mouth into the airway. This is a woman, a Polish lady who flew in from Warsaw, and the day she arrived, she fell down her daughter's steps, broke her neck, C2 complete tetraplegia, totally paralyzed below the neck, or almost totally paralyzed. And her vital capacity, her ability to take a breath, was 3 times less than a normal breath. She could not survive breathing on her own. So she was immediately intubated at University Hospital. And I was away lecturing, and I came in on Monday and found her like this. So we extubated her without putting a tracheostomy tube in her throat. How did we do it? Well, number one, to remove airway secretions, we use something called a cough assist. This is basically a vacuum cleaner. It's got a vacuum cleaner motor, at least the early ones. And from 1953 to 1967, this was on the market. And it was used by people who were in iron lungs and using non-invasive ventilation until 1967. But when it was learned that patients could be trached, all the people in the United States were told they should be trached. And the doctors and surgeons recommended traching them and trach them, and then they never used this machine through the trach tube. Of course, they could have, and it's far more effective than suctioning through a trach tube, because if you stick a catheter to try to bring secretions up through a trach tube, 90% of the time you don't get the left lungs, because the tube goes into the right airways. So 85% of pneumonias are in the left lung because you can't clear the secretions from them by suctioning. This device causes 10 liters a second of flow, and it doesn't care whether it's coming from the left or the right. It clears secretions from the entire lung. So we use the device on our intubated patients. I convinced Jack Emerson to put this back on the market in 1988. By the way, Jack Emerson was the man who in 1931 put the iron lung on the market. In 1931. And he's the only person who listened to me in 1988. In September of 1988, I said, look, we need this device back. He made it in November of 1988. He gave me one, and I immediately started using it in critical care to clear airway secretions. Now, to extubate somebody, they need to be able to breathe on their own and have an adequate cough and few secretions, and should be able to cough those secretions out. None of my patients can do that. But we extubate them anyway after we clear their airways of secretions. And after we do that, we use this device through a mask like this to clear the secretions so they don't fail extubation and have to get re-intubated. So we use this device, which is called today a cough assist and made by 8 companies in the world, to, through invasive airway tubes, to prepare patients for extubation, and after the extubation to maintain it, to see that patients don't have to get re-intubated. Think about your grandmothers or your older parents who were perfectly healthy, got a kidney stone, ended up in the hospital, got a little infection somewhere, maybe in the blood, got intubated, became too weak to breathe, and then the doctor said to them, oh, she's too weak to breathe, we have to put a tube through the neck. Well, it ain't necessarily so. Anyone who can cooperate sufficiently to keep their mouth closed and breathe through the nose does not need to have a tracheostomy tube if the problem is simply ventilatory failure. So we used this on this patient, and we showed her mouthpiece and nasal ventilation. She liked mouthpiece ventilation. She used a lip seal for the mouthpiece ventilation during sleep. And she actually slept without even using the lip seal, but she ventilated herself normally all night long anyway, and was able to go back to her daughter's house without a tube through her neck. This is another patient with spinal muscular atrophy type 1, Wernicke-Hoffman's disease. Again, she would have died as an infant if not for non-invasive ventilation. She had many pneumonias until 12 years of age, and each time she had to be intubated. But each time, except the last time, we extubated her. We took that tube out without sticking a tube in her throat. The last time, now she's 26 years old. The last time she was hospitalized when she was 12, we did not, that is my respiratory therapist and I, Lou Saporito, we did not extubate her to non-invasive ventilation. We let her mother do it. Her mother is so expert at managing her, better than any respiratory therapist you're ever going to meet, or any physician for that matter, that we said, okay, Mom, you extubate her. So Mom did, put her on her nose piece, and then she went home. That was 14 years ago, and she hasn't been hospitalized since. This is another woman with the same disease, SMA type 2, spinal muscular atrophy type 2, or type 3. I think she was able to walk a little bit when she was a kid. Twice at the ages of 10 and 27 years of age, she got pneumonias and was intubated. Both times she was intubated at Robert Wood Johnson Hospital. Both times the doctors wanted to put a trach tube in her throat. Both times she was transferred to us in Newark, and both times we extubated her back to non-invasive ventilatory support. Any other hospital that's not on our website, breathenvs.com, would have done the same thing. They all want to put tracheostomy tubes in because they don't recognize non-invasive methods as respiratory support, but they are wrong. It has been respiratory support since it was described in 1953, and I wrote the first big paper about it in 1993. But the fact of the matter is, there's just too much financial incentive to put the trach tubes in people. And there is the patient, and she's also a school teacher. Now, the little boy on the right, we took his trach tube out when he was a year and a half. He has a congenital myopathy. The boy on the left was intubated, could not be extubated in Hong Kong. His parents flew him in a private ambulance from Hong Kong to us to extubate him. And we, of course, did send him back to Hong Kong. That was about 7 years ago. But he had been intubated 3 times for respiratory failure. The third time, though, or fourth time, he could not be extubated because he was too weak to breathe. So they flew him to us and we extubated him. We published a paper on 157 cases in 2010. These are all people too weak to breathe, but we extubated them without trach tubes. And they had all these different diagnoses: Lou Gehrig's disease, muscular dystrophy, old age, and so on. And then another 98 cases we published in 2015. But nobody really does this except us. One of my friends, Dr. Nick Hill, wrote this paper in a pulmonary journal, Chest. Risk factors for extubation failure in patients following successful breathing trial. So these are patients who they found to be strong enough to breathe, but they failed extubation and had to get re-intubated anyway. So I wrote a letter, risk factors for extubation success in patients who are too weak to breathe. 4 out of 5 patients with trach tubes on ventilation die because of connections between the esophagus and the trachea, bleeding to death, mucus plugging, accidental disconnections, and so on, aspiration. Now, this is a patient with muscular dystrophy who got a tracheostomy tube and didn't want us to remove it. He was 19 years old when we met, on trach ventilation, and spent 29 years in a nursing facility at $850 a day for a total of $9 million. Today, it would have cost over $2,000 per day. Nursing homes are not paid DRGs. A DRG is a fixed sum of money to treat a patient. But nursing homes are paid per diem, over $2,000 a day for people on ventilators through trach tubes. So you can multiply this by almost a factor of 3. But at any rate, he cost taxpayers $9 million for 29 years in a nursing facility. This man, who is now 51 years old with the same disease, Duchenne muscular dystrophy, has been 24-hour vent dependent on non-invasive ventilation for 23 years. But because he doesn't have an invasive airway tube, he doesn't have a nurse. He doesn't really want a nurse. But he has, like the women I showed you before, a personal care assistance from the state at the minimum wage. That has cost a total of $500,000 over 23 years, as opposed to $9 million over the same period of time. And again, this was calculated about 5 years ago. So you can double these costs and cost savings. By my own calculation, I have saved New Jersey Medicaid and Medicare over $100 million over the course of my career, just for this one diagnosis, not including all the others, including Lou Gehrig's disease. And I have saved New York Medicaid and Medicare over $100 million also, most of that in nursing care, ongoing nursing care, which my patients generally do not get. Another man, the same thing, 17 years, 24-hour ventilatory support, $166 million for rental of the equipment, and not $60 an hour for nursing care. A spinal cord injured patient in our neurosurgical ICU, 1992. We took her trach tube out, put her on non-invasive ventilation, which she's still using today, at the age of 45, and has not had any respiratory complications since then. In 2010, 22 centers from our website from 18 countries got together and published data on just 3 diagnoses: Duchenne muscular dystrophy, Lou Gehrig's disease, and spinal muscular atrophy type 1, Wernicke-Hopkins disease. 760 patients on 24-hour non-invasive ventilatory support. I started publishing about removing tracheostomy tubes of ventilator-unweanable people in 1990. But my mentor, Dr. Alba, in New York City, was doing it since 1967. Why is it not being done? Well, doctors are paid by RVUs, regular value units. Figure about $100 per RVU. You get 11 3/4 RVUs to put in a tracheostomy tube in 15 minutes. You get 1 RVU for spending an hour to educate and train people how to avoid it. What about hospitals? Hospitals get paid DRGs. That's a fixed sum of money. But if you're on a ventilator in intensive care, and you get 3 times less than if you're on a ventilator for 5 days or more. So if you're on a ventilator and intubated for 2 days, as of 2 years ago, you got $14,000. But if you were intubated on a ventilator for more than 5 days, you got $40,000 at that time. It's of course more now. However, if you're on a ventilator for 3 weeks, you may not get an extra penny because you're paid a fixed sum, the DRG. So after 5 days, you make the most profit by discharging the patient to something called an LTAC, long-term acute care. They're paid a DRG also. Their DRG is over $150,000, but they start losing money if you're there for over 28 days. So they try to wean you from the ventilator. And if they do, or if they don't, you really need to go someplace after about a month. And that place is often a nursing home. Now, the nursing homes are not paid DRGs. They're paid per diem. For someone on ventilatory support through a trach tube, they're paid over $2,000 a day. If you're in a nursing home without a trach tube, it's about $400 a day. So the patients that are weaned in the LTACs are often put back on the ventilator in nursing homes so that 5 times the money can be charged to CMS. I surveyed 20 nursing homes in 2006, and I actually found that this was going on. And there's more, it's worse than that. There is no, you might ask, why don't I just present this to the insurance companies? And they're, of course, going to want to save a fortune by doing non-invasive management and letting me take trach tubes out and extubating people who can't breathe. They don't want to, because I've been told multiple times that the MCOs, the HMOs, if they spend less money, they get less money from Trenton. And they don't want to spend less money. They simply want reasons to increase premiums. I can't believe this. The first time I heard this, I didn't believe it, but it was told to me by multiple authoritative sources that the insurance companies, or at least the MCOs in New Jersey, really do not want to save this money. They don't want the patients to have to come to me intubated so I can extubate them, and they don't have to pay for the tracheotomies and the subsequent nursing care. I still find it hard to believe. Any of you out there from HMOs or MCOs, please comment on this. I'd love to hear it. Or refute what I'm saying. I wish you would. In New Jersey, all children in chronic vegetative states and who are comatose have private tutors. in our institutions that we taxpayers are paying for. Okay, well, if they don't understand what's going on and you have a teacher, a private tutor, that's one thing. However, all children with tracheostomy tubes, even those with no physical disability and not using a ventilator, get 16 hours a day of nursing care. Believe it or not, I have had a kid come into my office running all over the place with a tube in his throat. I asked the nurse, "What do you do for this boy?" And she actually said to me, "Well, his mother cannot manipulate the system." I said, "Manipulate the system? What do you mean?" "Well, she doesn't speak English." So that's why this boy had a nurse, costing taxpayers maybe $400,000 a year. So I examined the boy. I said, "I can take this trach tube out right now." And then the mother said, "No, then I lose my babysitter." I swear to you, this is a true story. And I'm sure this is not a unique story. Insurance premiums have been increasing 22% a year. My last stats on this were from 2017, 2016. But I'm sure they're going to increase a lot more than that because there are medications that are available now that are $500,000 a year for diabetes. There are medications for my patients that are $2.1 to $5 million. There are medications for my patients that are $1 million the first year and $500,000 every year thereafter. And that can be for 20 or 30 years. So we're talking about tremendous increases in expense for healthcare in the United States. There is no question that the insurance premiums will have to go up by more than 22% a year. And they're already over $20,000 for a family of four, well over $20,000. So that's American healthcare, whereas in Singapore, the government can pay 1% and guarantee it for everybody. So if you have an elderly mother or grandmother or father undergoing tracheotomy without first consulting a physician on the website breathenvs.com, you're subjecting that person to perhaps a very unnecessary invasive procedure that she would or he would be much better off not having. This was my last book on neuromuscular disease. It was 17 years ago or 16 years ago. I'm working on finishing it now, and in 2 volumes. The first volume is actually done. But I will stop here. It's 10:45, so there's 15 minutes for questions, and I would be happy to take on any questions that you may have about this. I'm used to lecturing to a medical audience, so I apologize if I did not adequately explain terms like intubation, tracheotomies, and so on. I hope you understood what I was saying, and you saw some illustrations of it. So I'll open it up to questions.
Dr. Bach, that was great. Thank you. I have a few questions here. The first question is non-invasive ventilation an option at hospitals across the country?
Well, yeah, but the physicians have to learn about it. And very few physicians, only the ones in breathenvs.com, have been willing to learn about it. Because in the acute care, it is extra work. There is no doubt about that. It's extra hours of work for therapists, maybe for nurses, and even for the doctors. And there's no incentive for extra work because there are no insurance codes to bill for it. So when I extubate someone to non-invasive support, it's a couple of hours of work. If you extubate somebody who's able to breathe, it's no work at all. There's no work at all. So there's no incentive physicians. In fact, in all the specialties in the United States, there is no incentive for physicians to learn how to keep anybody healthy, which is why 98% of medical students who are graduating are going into specialty care. When you go into general practice as a gatekeeper, holistic medicine, like the old-time physicians taking care of your problems and putting it together, there's no incentive for it because essentially the coding for billing is grossly inadequate, and you can't even make a living. Pediatricians are the least paid because they don't do so many invasive procedures, yet when they graduate medical school, they may have $500,000 of debt. How can they learn how to keep people healthy if they can't make a living doing it? In fact, nobody could make a living taking care of my patients the way I do. I can only make a living on my salary as a tenured professor, but I cannot cover my salary by keeping these patients healthy and alive and without invasive airway tubes in their throats. If I can't do it, and I know that medical students graduating medical school and doing residencies can't do it, then how can anybody learn how to keep people healthy with quality of life in the American healthcare system the way it is.
Oh my goodness. Thank you so much for that explanation. So the other question, I think, I'm still going to ask it, but you kind of just answered it. Is non-invasive ventilation currently being used to treat COVID patients?
Not enough. In the centers, yes. And let me explain about COVID. Now, one of the criteria for extubating somebody who's too weak to breathe is that they must not be hypoxic. Their oxygen levels should be normal. However, with COVID-19, it's the opposite situation. Their problem is not that they are too weak to breathe. Their problem is that they cannot get the oxygen into the blood. So the treatment for that is oxygen. Now, when you give somebody oxygen who's too weak to breathe, it basically tells the brain, you don't have to breathe because your oxygen is okay. So the non-invasive ventilation that could go through the nose will leak out of the mouth and it won't work. But you can ventilate someone through a closed system of covering the nose and mouth and feed the oxygen in that way. It's a little bit of extra trouble, but it's important to do anyway because you don't want patients exhaling viruses everywhere anyway. So it's good to ventilate them through something covering the nose and mouth. Now, where non-invasive ventilation can be important is two ways. First of all, when you say non-invasive ventilation to a doctor, they immediately associate it with something called CPAP, which is continuous non-invasive positive airway pressure, which is what old people who snore and have obstructive apneas get to keep their airway open so they can use their muscles to breathe. CPAP is totally useless for patients with weak muscles, but they're getting it anyway because the sleep doctors are prescribing it because that's what they know. Then there's something called BiPAP. That's bi-level positive airway pressure. That's where you get a continuous flow of air to try to keep the airway open, but when you inhale, the air pressure is a little bit higher, so that helps you breathe. When you have COVID-19, you need both. You mainly need to keep the airway open so that the oxygen can get to the blood. So you don't necessarily need the ventilatory support when you inhale. You need a constant flow of air to keep the airway open. But because of the oxygen, the non-invasive ventilation is more difficult to use. Now, when you're intubated for a week or two, you, like anybody else, get too weak to breathe anyway, just by being in critical care and intubated, plus the virus can attack the nervous system and make you too weak to breathe also. That's the point where non-invasive ventilation can be very, very helpful because patients who are intubated can be extubated to it instead of getting tracheostomy tubes. And when patients get tracheostomy tubes, they could go to LTACs, long-term acute care, and the trach tube can be removed almost immediately for non-invasive ventilation. But again, nobody's doing that. The best way to do it is to avoid the trachs in the first place. And it's not clear that you can always do that because if a patient needs high oxygen concentrations, it's more difficult to use non-invasive ventilation. But the elderly with critical care, myopathies and neuropathies and deconditioning, they're very often quite able to simply get air through a nose piece without having to get a trach tube in their throats and die with the tube in their throats. And often they die because of the tube in their throats.
Okay, thank you. We have another question here that says, in your opinion, what is realistic in terms of changing and improving the U.S. healthcare system to eliminate the fee-for-service incentives and become more patient-centric?
There is no a bankruptcy by the government is all that can do it, I think, because, before I lectured in Singapore, I thought that the Canadian and European systems were better, like Medicare for everybody. Well, yeah, it's better. To have Medicare for everybody is better, but the patients who don't pay abuse the healthcare system, the doctors abuse the healthcare system, and the insurance companies abuse the healthcare system. There are 5 administrators in a hospital in New York City who earn over $10 million a year because hospitals charge by something called the charge master. And if you don't have insurance, they can sue you for a fortune, which is why so many people in the United States have to declare personal bankruptcy. The Singapore system, in my opinion, is by far the best because medicine is a marketed thing that people have responsibility for what they get, what they pay for, The doctors have to put what they do and what they charge for it on the internet. The patients are using their money to pay for it. Now, obviously, we could not switch to a system like that the way the United States is today. It's not possible. But healthcare expenses will continue to increase by $500 billion a year. Right now, we are in debt by about 23 or 4 trillion. Of course, that's before COVID-19. Make that 26 or 27 trillion. That comes to about $100,000 per American. So whether or not you think Americans are born in original sin, I can guarantee you we're born in original debt. Everybody born in the United States owes the federal government about $100,000. Now, the government has unfunded commitments of over 100 trillion to $250 trillion a year, unfunded commitments. So even though we are in debt about 23 trillion or 26 trillion, after the government pays for the pensions, the medical care, and everything else it's pledged to pay for that has no money to pay, we're talking about well over $100 trillion a year, or about $800,000 per worker. I mean, you know, this is absolutely ridiculous. Nobody can ever pay back this money. The Federal Reserve is a profit institution that prints money and makes money on the interest that the government pays. It has every interest that the government pay more and borrow more money so that the wealthy people get wealthier in the United States. I don't see any solution. I mean, if Switzerland were on our border or Singapore, I would move my resources there. We are in big trouble as a country, and mainly because we got away from personal responsibility, raising our children, helping our parents, paying for what we get. My 77-year-old uncle was entitled to food stamps, but in those days, in my parents' and grandparents' generation, that was called going on the dole. That was a disgrace. Today, the more money you can get from the system by manipulating the system, literally, the more you're looked up to. America today is not the America or the Americans that sacrificed together to win 2 world wars in the 20th century. We are simply not the same people. And I don't see how we can get back to being the same people. You know, when I first landed in Singapore, I saw people who were happy to work, who never even thought about going to the government for a handout because there would be no handouts. And I thought to myself, gee, this is like the United States that I grew up in before 1965. So I'm really saddened by what I see and perceive as Americans to become. You know, most of the medical students in our school are women and people from Asia, and this is like this in other medical schools too. My own son spent most of his time playing video games and never got a college education. I think that people in the United States, because they may see their mother on welfare, overweight and being paid and getting money anyway and having cell phones and televisions, their children are not necessarily learning a work ethic. They're simply not, because they're not going to die even if they don't work, and they know that. That wasn't the case in my parents' generation and in my grandparents' generation. My father dug graves when he was a young adolescent to make money during the Depression. Young people don't have to worry about that anymore, do they? But the government cannot keep printing money that's backed by nothing and get away with it. So I don't know what the ultimate answer is going to be. Anyone who talks about accountability on the part of our politicians will never be voted for, and that's a sad state. I mean, we went from George Washington, John Adams, and Thomas Jefferson to George W. Bush, Barack Obama, and Donald Trump. Need I say more? Need I say more?
Dr. Bach, thank you so much. If the audience wants to reach out to you or about further questions they have, maybe about a family member or anything along those lines, what's the best way to reach you?
Well, go onto the website. You have my email address there, telephone number. All these centers in the United States, in fact, in the world, that you can count on to use non-invasive ventilation are on that website. There are extremely few in the United States because, again, there's no incentive to actually learn this. But there are in Pittsburgh, in Boston. Unfortunately, ours is the only one that takes care of children and adults, because most physicians take care of only children or only adults. So that is a bit of a problem. But there are some centers, for example, in Ottawa, in Canada, where they have great physicians who do both, who take care of children and others who take care of adults. There's really few others. There's one in Dallas, who's wonderful. In Seattle, excellent. But I just don't know any others. In New York City, for example, in New Jersey, there certainly aren't any. In fact, there are critical care doctors who brag about how many trach tubes they put in, rather than when I tell them, I can explain to you how to extubate these people without trach tubes. They say, no, I put in 30 last year myself, or 30 last month. I mean, it's just incredible. And they pay no attention to the long-term problems of people with, if you have a trach tube, 30% of people aspirate food and liquid into their lungs because of the trach tube. And even if you take that trach tube out, 7% for the rest of their lives aspirate, which gives them a greater risk of pneumonia and respiratory failure. That's just one example of the long-term problems of tracheostomy tubes that many of these patients simply don't need. But they are put in because ever since 1953, when physicians learned they could make money by putting in trach tubes, they tried to convince everybody. Now, in those days, people were in iron lungs. But in 1953, Dr. Affelt in Ranchos Los Amigos in Los Angeles said that the funny thing, the patients and the therapists were fiddling with the equipment. They put it in the patient's mouth, and all day long, the patient could use mouthpiece ventilation and didn't go back in the iron lung. And these patients don't want trach tubes. They all refuse trach tubes. When I was a resident at Goldwater Hospital for New York University in the 1970s, none of the patients had tracheostomy tubes. And Dr. Alba, my mentor, became the medical director of the hospital. She took the patients out of iron lungs in 1956 and simply let them use non-invasive ventilation. And this was before I described nasal ventilatory support in 1987. So these patients just had mouthpieces and lip seals to use overnight. None of them got trached. And that's because of Dr. Alba in New York City. But none of the surgeons wanted to learn this. None of the critical care people in New York City to this day want to learn it. None. And if there's any exception, I wish they would contact me, because they're traching people who don't need it in many, many cases. So that's the way it is. And it's because of the fee-for-service healthcare system that that's the case. Now, my book that I'm working on, I'm finishing the second volume of my neuromuscular book, is being simultaneously translated into Spanish and Chinese by 9 people from 4 different countries in South America and in Spain. All of these people came to stay with me for months to up to a year to learn what I do. From Chile, Argentina, Brazil, from Colombia, from Paraguay, from Spain, and from other countries too. Korea, Taiwan, China, mainland China, all came to stay with me for months to learn what I do, and they are centers on the website. I have had maybe 2 or 3 Americans since 1953 come to learn what I do. One is in Connecticut, and they're on our website. There's one, I think, in Boston, and one in, I don't know anybody else. There's certainly one in Dallas, but that's about it. And yet I have had 100 people easily from other countries who want to learn how to keep people healthy and free from invasive airway tubes. Why? Because they don't get paid for putting in tracheostomy tubes. Doctors are generally paid salaries, and their goal is to actually keep people healthy. And what I do is cheap, because it doesn't involve nursing care. And in the United States, you get nursing care if you have invasive tubes, you see? And they don't give nursing care in South America, paid for by the government. So naturally, they want to avoid high technology interventions that require airway suctioning and equipment and supplies and all of that. And so that's the problem with the American healthcare system. It's not geared towards keeping anybody healthy in any specialty. And I mean, I could tell you this about what happens in cardiology, what happens in oncology, what happens in surgery, what happens in almost every other field. And other people have done this. But I can only talk personally about what's happening in respiratory care in the United States.
Well, Dr. Bach, thank you so much. On behalf of the Rutgers University Foundation, we'd like to thank you for sharing your time, your wisdom, your expertise this morning. Thank you to all the attendees for joining. Everyone stay safe and healthy during this time. We hope to see you soon.
Oh, by the way, can I say one other thing? You know, I put three videos on Facebook and on YouTube about how to solve the COVID problem. The first video, I said that our lockdown was completely inadequate and it wasn't going to work. And of course, I was right. I predicted that we'd have more deaths than in the Korean and Vietnamese War. And of course, I was right about that too. But my last video, well, the reason what I suggested initially was a Wuhan type lockdown, where only sanitation workers and healthcare professionals could actually go out for 1 month. Then mathematically, nobody in the street could have the virus. But anyway, that's finished now because people are fed up with this impartial, this half-baked lockdown. And I understand that we're suffering from this now for the next year or so, at least, with all the deaths that are going to occur because it wasn't done properly in the first place. But my last one, about a week ago or 2 weeks ago, I said that we really need 1 billion tests for adequate, good tests for antigen, maybe RNA, and certainly antibodies. And everyone should carry an ID card, a COVID status ID card, so that we can know that if we go to a Broadway show or a baseball game, the person next to us cannot have COVID-19. Now, about a day or two ago, I heard on the radio that in other countries, they were making COVID passports and basically doing exactly what I suggested over a week ago, but I have not heard this from anybody in the United States. And until we get a vaccine, which is not absolutely certain that we'll ever have one because the virus is mutating very rapidly, I think that that is the solution. So anyway, I leave that to you also. These videos, you could take a look at them. I was right. And I also said in one of my videos that I wouldn't be surprised if we have more deaths than occurred in World War II. You know, we fought for 20 years in Vietnam, and we lost 58,000 people. We've surpassed that in just a month or two by COVID-19. And frankly, I'd rather face an invisible virus than a Viet Cong machine gun in the jungles of Southeast Asia. I had a lottery number of 36. I could have gone to Vietnam, you see. So we older people have been through other crises in the past. This is not the worst of the crises that we have seen. We had AIDS. There are, not many people alive today, but there was the 1918 flu epidemic and so on. But in those days, Americans worked together to solve the problem. We are not doing that now. The Chinese did, the Chinese are, the South Koreans are, and have. In Israel, they have, from the beginning, quarantined everybody entering the country to be sure they didn't have COVID-19, to get a handle on it there. And they're living essentially normally in Israel. I understand from my colleagues over there. That's what they tell me. Because they were extremely aggressive from the beginning. What did we do from the beginning? Our politicians said, oh, this is a democratic hoax. They just simply denied the existence of even a problem. This is the difference between politicians who can face reality and those who can't, who don't want to. And that's the difference. So it has been handled better in some countries, in South Korea, in Singapore, in Israel, I believe, but it certainly wasn't handled well here. And we're paying for that now in deaths of Americans. And I hope I'm wrong about 420,000 deaths occurring before this is over, which is how many people we lost in World War II. But I was right about Korea and Vietnam, wasn't I?
Well, I think we all hope that we were wrong when it comes to the deaths there.
Yeah, I hope so too.
Unfortunately, at this point, I guess only time will tell, but thank you so much for your time.
It's my pleasure. Anytime. It's really a pleasure. Thank you. Thank you. Thank you.
Have a great day.
Bye-bye.
Bye.